Slide 1. This slide tape unit presents a discussion of heart muscle mechanics. Slide 2. This unit presents 6 major topics. 1. Ventricular dynamics elucidated by mechanical principles derived from papillary muscle. 2. The 4 phases of the ventricular contractile cycle. 3. The 4 phases of the afterloaded isotonic contraction in papillary muscle. 4. Determinants of initial muscle length. 5. Relation between contractility and variation in activation level of myofilaments and function of inotropic agents. 6. Relation between muscle tension and rate of shortening. Slide 3. The objective of the first section is to enable you to state how mechanical principles derived from papillary muscle can be applied to elucidate principles of ventricular dynamics. Slide 4. To understand the mechanics of the heart, we need to know something of the structure at the molecular level and how the elements interact to bring about force generation and shortening. Much of this is covered in other slide tape presentations in this series, but let us highlight certain features by looking briefly at the molecular structure. Slide 5. Here we see a schematized representation of this molecular structure. As you know, the thick and thin myofilaments interdigitate and can slide by one another. When calcium is present around these myofilaments, cross bridges radiating from the thick filament are thought to interact with sites on the thin filament to generate sliding motion. Slide 6. If there is little or no restraining force or load, sliding will occur such that the Z to Z distance will shorten. That is, the sarcomere length will decrease. Slide 7. On the other hand, if the load is large enough, or if the ends of the muscle are held fixed, no shortening can occur, and the contractile energy will be delivered in the form of tension development rather than shortening. The mode of contraction, then, depends on the nature of the imposed loading conditions. Slide 8. Much of the knowledge of the mechanics of cardiac muscle has been obtained from experiments with papillary muscles. Compared with cardiac muscle from the ventricular wall, mechanical studies on papillary muscle are relatively easy to interpret since these muscles are relatively long, thin, and almost cylindrical, with fibers running parallel to the long axis of the muscle. And as far as we can tell, their mechanical properties are representative of those of the ventricular wall. Slide 9. Freshly excised papillary muscles are placed in an oxygenated bath and electrically stimulated to trigger contraction. Slide 10. The variables of interest in a stimulated papillary muscle are usually the time course of tension, T, length, L, and rate of change of length, or shortening velocity, dL dt. Slide 11. These papillary muscle variables can be related to ventricular variables by thinking of the papillary muscle as an element of the ventricular wall. We can think of the mechanics of the papillary muscle as representative of the mechanics of a sample population of ventricular fibers. Slide 12. Papillary muscle shortening is then related to ventricular wall shortening. Slide 13. Ventricular wall shortening, dL dt, is in turn related to the decrease of ventricular volume, or ejection. Thus, the amount of muscle shortening is indicative of the stroke volume ejected by the ventricle. Slide 14. The tension, T, developed by the muscle is representative of the ventricular wall tension. This wall tension is related to the pressure in the ventricular chamber in much the same way as pressure in a balloon is related to its wall tension, except that in the heart, the energy source is in the wall rather than in the chamber. In either case, the higher the pressure, the higher the wall tension. Slide 15. The relations between muscle tension and chamber pressure, and between muscle shortening and ejection, form the basis for applying the mechanical principles learned from papillary muscle to the ventricle. Slide 16. From a practical point of view, what we would really like the papillary muscle experiments to tell us is what factors determine the amount of shortening during a contraction. This is important because the amount of shortening in the ventricular wall determines the ejected stroke volume. The ejected volume per beat is of paramount interest. For example, the clinician often needs to find ways of increasing stroke volume in failing hearts. We will see that there are several means of achieving this. Slide 17. To assess your understanding, complete this relationship. Stop the tape while you answer. Slide 18. Slide 19. The objective of this section is to enable you to identify the 4 phases of the ventricular contractile cycle. Slide 20. To utilize the papillary muscle to study the factors influencing shortening, we need to program it to go through the same type of contraction as a segment of ventricular wall. In other words, the time course of tension and shortening in the papillary muscle should be similar to that actually experienced by ventricular fibers. Slide 21. We can determine this sequence by examining mechanical events occurring during a ventricular contraction cycle. Here we see the left ventricle with its 2 valves, the mitral valve on the input side and the aortic valve on the output. Slide 22. The next few slides show the time course of pressure and volume change during a contraction. The dashed line represents an idealization of the actual pressure waveform, which we will use from here on for simplicity. Slide 23. The cycle is broken into 4 phases. Notice that during each of the 4 phases, either the pressure or volume waveform is flat. That is, either pressure is constant or volume is constant. Slide 24. During phase 1, the pressure rises. All valves are closed during this phase, so there is no volume change. Slide 25. Then, when the pressure grows high enough, the aortic valve opens and phase 2 begins. Ejection occurs, so ventricular volume decreases, but pressure remains constant to a first approximation. This pressure is often referred to as the afterload pressure, or simply the afterload. Slide 26. When ejection ceases, the aortic valve closes and phase 3 begins. Ventricular pressure falls rapidly, and since all valves are closed, there is no volume change. Slide 27. During phase 4, the mitral valve opens and filling occurs to bring ventricular volume up to its pre-contraction level. There is actually some increase of pressure during phase 4, but it is small compared with developed pressures. Slide 28. So we see that the contractile sequence is readily broken into 4 phases. 1 and 3 are characterized by constant volume, while 2 and 4 are characterized by constant pressure. These pressure and volume changes in the ventricular cavity are paralleled by similar changes in the ventricular wall, except that the latter are expressed in terms of tension and length instead of pressure and volume. Slide 29. For review of this section, list the 4 phases of the ventricular contraction cycle, and for each phase indicate to a first approximation how pressure and volume change. Increase, plus; no change, 0; decrease, minus. Stop the tape while you fill in the chart. Slide 30. Slide 31. This section should enable you to identify the corresponding 4 phases of the afterloaded isotonic contraction in papillary muscle. Slide 32. As we see here, the tension and length changes in a ventricular wall segment are similar to the pressure and volume changes in the ventricular cavity. Phases 1 and 3 are of constant length, while phases 2 and 4 are of constant tension. Slide 33. Since we want the mode of contraction of our papillary muscle to be similar to that of ventricular wall fibers, we need to program our isolated papillary muscle to undergo this very contractile sequence, which is often referred to as an afterloaded isotonic contraction. Slide 34. We see that phases 1 and 3 are characterized by constant length. For this reason, those phases are referred to as isometric. Slide 35. Phases 2 and 4 are characterized by constant tension and are called isotonic. The level of tension during phase 2 is called the afterload tension, or simply the afterload. We will see that its level is one of the crucial factors in determining how much shortening occurs in a contraction. Slide 36. What is of prime interest to us is phase 2. How much shortening occurs, and what factors determine the amount of shortening. Bear in mind that shortening in the papillary muscle is analogous to shortening in the ventricular wall. To help look at this, let us construct a tension length diagram for the afterloaded isotonic contraction. Slide 37. During phase 1, the tension rises, but the length remains constant. During phase 2, the tension is constant while the muscle shortens. Then, during phase 3, the tension decreases at constant length. Finally, during phase 4, initial length is restored. Delta L, the amount of shortening during phase 2, is the quantity of interest. Slide 38. For review of this discussion, list the 4 phases of afterloaded isotonic contraction of papillary muscle, and for each phase, indicate how length and tension vary. Stop the tape while you fill in the chart. Slide 39. Slide 40. Experiments have shown that there are 3 important factors which influence the amount of shortening. First, the initial length of the muscle when the contraction begins. Second, the level of myofilament activation by calcium during the contraction. And third, the afterload tension level placed upon the muscle as it shortens. Let us look at each of these one at a time. Slide 41. Your objective in this section is to state the determinants of initial muscle length. Slide 42. The initial length is determined by the amount of tension applied to the muscle just prior to the contraction. This relatively small tension is usually called the preload. The higher the applied preload, the longer the muscle length. The length tension characteristic is much like that of an elastic band. The length depends on the amount of tension used to stretch it. Slide 43. Much of cardiac muscle elasticity may reside anatomically in the connective tissue surrounding the muscle fibers. Thus, it is usually thought of as an elastic, spring-like element functionally in parallel with the myofilaments, as illustrated on the slide. It is usually called a parallel elastic element, or PE. As illustrated on the slide, the larger the preload, the greater the stretch of both the PE and the sarcomeres. Slide 44. Preloading the muscle adequately is crucial. The more the muscle is pre-stretched, within limits, the more vigorously it contracts, and the more it can shorten during a contraction. Slide 45. This initial length dependence is illustrated here. The bold curve at the bottom is the length-tension relation of the unstimulated papillary muscle, the one we just discussed. We see a muscle contracting from 3 different initial lengths, which were set by 3 different preloads. Phases 3 and 4 are omitted to reduce the clutter. Slide 46. At the unstretched initial muscle length, the tension first increases to the imposed afterload level and the muscle shortens. Slide 47. If the muscle is more heavily preloaded, that is, pre-stretched, the amount of shortening during contraction increases rather substantially, as illustrated by the rightmost pathway. Slide 48. Translating this principle to the heart, we see that one way of increasing the stroke volume is to pre-stretch its fibers by distending it with more blood. The ability to shorten more with increased pre-stretch, which results in an increased stroke volume, is known as the Frank-Starling mechanism. It is one of the fundamental properties of heart muscle. Slide 49. To assess your understanding of this section, answer these questions. Stop the tape while you answer. Slide 50. Slide 51. The purpose of the next section is to enable you to state the relation between contractility of the heart and variations in the activation level of the myofilaments, and to define and give examples of inotropic agents. Slide 52. The second of the 3 factors governing the amount of shortening is the level of myofilament activation. As calcium diffuses toward the myofilaments after stimulation, the level of myofilament activation increases and reaches a peak. Slide 53. Later in the contraction, after the calcium begins to be withdrawn from the myofilaments by the sarcoplasmic reticulum, the level of activation decreases towards 0. Slide 54. A similar cycle is followed by the muscle's ability to shorten at each instant. At the peak of myofilament activation, the muscle can shorten most rapidly. During the rest period between beats, little or no shortening can take place. Slide 55. The amount of shortening during a contraction depends on the average level of myofilament activation during the contraction, or more specifically, during the period of shortening, phase 2. Obviously, the higher this is, the more vigorously the muscle will contract, and the more it will shorten, as shown on the slide. Slide 56. The average level of activation during the contraction is sometimes loosely referred to as the contractility of the muscle. Slide 57. Agents which increase the contractility of the muscle do so by increasing the level of activation. These are called positive inotropic agents. Negative inotropic agents are those which decrease the contractility of the muscle by decreasing the average level of myofilament activation during the contraction. Slide 58. For example, norepinephrine is a positive inotropic agent. It increases the level of myofilament activation and increases the amount of shortening. Halothane, a general anesthetic, on the other hand, is a negative inotropic agent. When exposed to halothane, the muscle will not shorten as much as in the control state. Thus, the clinician can increase the stroke volume of the heart through judicious administration of positive inotropic agents. Slide 59. To check your understanding of these concepts, state the relation of myofilament activation to contractility. Stop the tape while you answer. Slide 60. Slide 61. Complete these sentences. Stop the tape while you answer. Slide 62. Slide 63. The objective of the next section is to enable you to name the third factor in addition to initial muscle length and myofilament activation level, which influences muscle shortening, and describe its effect. Slide 64. The third factor influencing the amount of shortening is the level of afterload tension. There is a simple relation between the tension a muscle is exerting on a load and the rate at which the muscle can shorten. Slide 65. The two are inversely related, as we see on the curve. The higher the afterload tension on the muscle, for example, point A, the lower the shortening velocity. The lower the load, for example, point B, the higher the shortening velocity. Slide 66. The inverse relation between load and rate of shortening is characteristic of all striated muscle and follows the common experience of lifting a load. A heavy load, corresponding to a high afterload tension, can only be lifted slowly, but a light load can be lifted much more rapidly. Slide 67. The inverse relation between shortening velocity and load means that a muscle contracting against a high afterload will shorten relatively slowly. By the time the contraction is over, it will therefore have shortened relatively little. So, the higher the load, the lower the amount of shortening during contraction, all other factors remaining unchanged. Slide 68. This principle is illustrated on this slide. 3 contractions are shown on the left, each with a different afterload tension level. The corresponding amounts of shortening are shown on the right. There is less shortening with the high afterload level than with the lower afterloads. Slide 69. To apply this principle to the ventricle, we need to recall the idea of the papillary muscle as a model of ventricular wall segment, as shown on the left. Remember that the tension in the wall segment is directly proportional to the pressure in the ventricular chamber, and the segment shortening velocity varies with ventricular outflow rate. Slide 70. Therefore, if tension and shortening velocity are inversely related in the ventricular wall segment, it follows that pressure and outflow rate must also be inversely related in the ventricle. Slide 71. The lower the pressure load on the ventricle, the higher the outflow rate. So if the clinician wishes to increase the outflow rate, and hence the stroke volume, he may elect to do so by reducing the pressure load faced by the ventricle as it ejects. Slide 72. In actuality, the relation between pressure and outflow rate, or between tension and shortening velocity, is not quite as simple as illustrated here. For instance, the curve may shift upward or downward depending on the instantaneous myofilament activation level or the instantaneous muscle length. Furthermore, the exact shape of the curve has not yet been elucidated. Nevertheless, the general principle, the higher the load, the lower the velocity, is a useful one to remember. Slide 73. Answer this question to assess your understanding of this principle. Stop the tape while you answer. Slide 74. Slide 75. We can recapitulate by asking a clinically relevant question. How can we increase stroke volume of the heart? Or, equivalently, how can we increase the amount of shortening during contraction? There are 3 methods we have discussed. Slide 76. The first is to increase the initial muscle fiber length by stretching the ventricle with a larger preload tension. Increasing venous filling pressure achieves this. Slide 77. The second way is to increase the myofilament activation level, that is, increase the contractility. This can be effected by exposure to appropriate positive inotropic agents, such as norepinephrine. Slide 78. The third way is to reduce the afterload tension against which the muscle is contracting. This can be achieved by taking therapeutic actions which reduce the arterial pressure. Slide 79. As you will see in the slide tape entitled Indices of Performance, Clinical Application, all three of these mechanisms form the bases for useful clinical tools. Now that you have completed this slide tape, you should review the major points listed in this slide. Once having satisfied yourself that you understand each topic, you should then take the post-test in the study guide. Credit slide.